Alaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Dear students of fourth year MBBS, today we will discuss very briefly about corneal dystrophies and we will discuss the corneal ectasias, particularly the keratoconus. The learning objectives of this lecture are: we want to know and have an overview of different corneal dystrophies. And we want to know about corneal ectasias, particularly symptoms, signs, diagnosis, and treatment of keratoconus. What are the corneal dystrophies? The corneal dystrophies are a group of progressive, usually bilateral, mostly genetically determined, non-inflammatory opacifying disorders. Age of onset is usually first to 4 decades, depending upon the type of dystrophy, but most of the dystrophies presented in first and second decade. In this picture, it is shown different layers of the cornea. At each layer is having its own dystrophy, and outermost layer is the epithelium, which is stratified squamous non-keratinized epithelium, multi-layered epithelium. Basal cells are columnar. Then comes the Bowman layer, which is an acellular superficial layer of stroma. And stroma is a regularly arranged layer of collagen fibers, and spacing is maintained by proteoglycans. And Descemet's membrane is a thin basement layer of endothelium. And the endothelium is a single layer of hexagonal cells which cannot regenerate once they are degenerated. So the different layers have corneal dystrophies, and the epithelial dystrophies are epithelial basement membrane dystrophy and meseman dystrophy. And different dystrophies of the Bowman layers are, the most important is the Rees-Buckler dystrophy. The stromal dystrophies are lattice dystrophy, which further divided into type 1 to 3, macular dystrophies, and granular dystrophy. And in the endothelial layer, the Fuchs endothelial dystrophy is most important. What is the epithelial basement membrane dystrophy? It is also known as Cogan microcystic map dot fingerprint dystrophy. Onset is usually in the second decade, and a few patients develop recurrent corneal erosions in the third decade, which is very, very painful, and patient is uncomfortable and unable to perform the day-to-day working. Here you can appreciate the different presentation of this dystrophy: dot-like figures, epithelial cysts, fingerprints like maps, and map-like additions. In epithelial basement membrane dystrophy, you can also appreciate dot-like opacities. Here you can appreciate in this picture dot-like opacities and epithelial microcysts and the subepithelial map-like patterns in the lower figure. And the other type of epithelial dystrophy is the Meesmann dystrophy. It is autosomal dominant inheritance. Onset usually in the second year of life. And in this case, you can appreciate intraepithelial cysts, maximal in the central region. And the Bowman layer Rees-Buckler dystrophy is the autosomal dominant inheritance. Onset is usually in early childhood with recurrent erosions. You can also appreciate polygonal opacities in Bowman's layer, and the sensation of the cornea is reduced. And usually visual impairment is there due to scarring at Bowman's membrane level. The stromal dystrophies, the most important is the lattice dystrophy. In this case, Inheritance is autosomal dominant. Presentation is in first to third decade. Here you can appreciate fine spidery branching lattice lines, best seen on retroillumination. In this picture, you can see the spidery lines. Now, we briefly discuss the macular dystrophy. This type of dystrophy is the least common dystrophy, but it is visual impairment is more serious in this case of dystrophy. There is systemic inborn error of keratin sulfate metabolism, and inheritance is autosomal recessive. Usually presentation is in first decade with gradual deterioration of vision. In this picture, you can appreciate macular dystrophy where you can see the focal poorly delineated spots in the anterior stroma with irregular corneal surface may be present, and opacification of the cornea, it increases with the passage of time, and ultimately full thickness stromal involvement with thinning is present, and visual impairment is most marked. Then comes the granular dystrophy. Inheritance is autosomal dominant, usually present in the first decade of life, and you can see the sharply demarcated deposits resembling crumbs or snowflakes in the central interior stroma. Now the Fuchs endothelial dystrophy, in this case the autosomal dominant inheritance is proposed. It is a slowly progressive disease in old age, and usually the gradual increase of central guttata with peripheral spread and beaten metal appearance is there. Endothelial decompensation may be present, causing central stromal edema and blurred vision. There may be persistent epithelial edema leading to bullous formation or the bullous keratopathy once the bullae rupture, causing pain and discomfort. All about the dystrophies. Now we will discuss briefly the corneal ectasias, particularly the keratoconus. Keratoconus is a progressive disorder, usually having puberty onset, and the cornea assumes conical shape secondary to stromal thinning and protrusion. This keratoconus progresses slowly until the third and fourth decade, when the progression is usually halted. Usually the bilateral involvement is there with asymmetrical presentation. Hereditary role is not clearly defined, but autosomal dominant transmission with incomplete penetrance is proposed, and only 10% offspring may be affected. Now, the association of corneal ectasia, particularly the keratoconus, are the diseases which affects the collagen tissue and elastic tissues of the body, as the Down syndrome, Turner syndrome, Ehlers-Danlos syndrome, Marfan syndrome, atopy, osteogenesis imperfecta, and mitral valve prolapse. And the ocular associations of this disease are the vernal keratoconjunctivitis, bleusclera, aniridia, ectopia lentis, and retinitis pigmentosa. Whenever there is keratoconus, you look for these diseases. How can we classify the keratoconus? According to the size of the cones, we can classify as the nipple cones are the smallest one, having diameter of about 5 millimeter, oval cones 5 to 6 millimeter, and the globus cones more than 6 millimeter of the cornea. So how the keratoconus presents? The symptoms of the keratoconus are it is usually typically unilateral visual impairment at the presentation, but later other eye is usually involved, though the involvement of both eyes is asymmetrical. And this visual impairment is due to progressive thinning, protrusion causing myopia and astigmatism, ultimately the irregular astigmatism. How can we diagnose a case of keratoconus? The hallmark of keratoconus is central or paracentral stromal thinning with apical protrusion and irregular astigmatism. And the keratoconus can be graded according to keratometry of the cornea or the power measured in diopters. Mild keratoconus means the dioptric power of the cornea is less than 48 diopter, moderate 48 to 54, and severe keratoconus having measurement more than 54 diopter. What the signs you have to look for in a case of keratoconus? You must look for Munson sign. Once you ask the patient to look down, a conical shape of the cornea will protrude the lid outward. You will observe the oil droplet sign on direct ophthalmoscopy. And if you do this retinoscopy, there will you not find the regular slit-like movements. Rather, it is seizure reflex, haphazard movement of this slit. Then you can find the stromal striae, also called the Vogue lines, and the Fleischer ring deposition of iron deposition subepithelial around the cones. And you can observe the progressive corneal thinning. In this picture, you can appreciate the Munson signs. Patient is looking downward and the cone protruding along with the lower lid outward. In this picture, you can appreciate the oil droplet sign. Once you do the distant direct ophthalmoscopy, you will see that as oil is present in the eye, it is just due to the reflections due to irregular shape of the cornea. And of course, once you will see the posterior fundus, the optic disc will be tilted, but the cause is in the cornea, not in the disc. In this picture, you can appreciate the vertical lines. They are called Vogue striae or Vogue lines in the stroma. Once you put a pressure on the cornea and observe under the slit lamp, these lines usually disappear. Here you can appreciate corneal thinning and protrusion of the lower part of the cornea. And this interior view of the cornea and the slit examination on the right side of the picture. In this picture, you can appreciate where the rupture of Descemet's membrane is there and the aqueous influx into the cornea causing the corneal edema. And ultimately, the healing have occurred with the corneal opacity on the right side of the picture. That is also blessing in disguise. Once the Descemet's membrane rupture, aqueous influx is there, and ultimately healing with this cornea scarring, it somehow halt a little bit progression of the keratoconus later on. In this picture, you can appreciate the corneal topography. By the corneal topography, you can measure the dioptric power of different parts of the interior and posterior cornea. On the right hand picture, you can appreciate severe keratoconus and early paracentral cone in left eye. The red color is showing high power, then comes this orange, then yellow, then green, and blue color is having the least power. So up to now you have diagnosed the case of keratoconus. What is the treatment of the keratoconus? Initially, you can mm, correct the vision to some extent with the spectacles, spherocylindrical lenses, but ultimately, once the irregular astigmatism is there due to the progressive protrusion of the cornea, it is not possible to correct the vision with the spectacles, and we can use the rigid contact lens, but ultimately they also fail. You can halt the progression of the this keratoconus by the cross linkage. Cross linkage is a process in which we sensitize the corneal lamellae with the riboflavin, having two types, epithelial and transepithelial. In case of epithelial, we remove the epithelium, and for half an hour we put drop by drop the riboflavin which sensitize the cornea, and then we give ultraviolet radiation which causes sclerosis of the corneal lamellae. So the progression of the keratoconus is halted, but it does not improve the vision. We can use the intracorneal ring. In case of intracorneal ring, as you can appreciate in this picture, we create a manual tunnel or the tunnel with the help of femtosecond laser. And then we put a ring around this cone into this tunnel elastic ring, which pulls the periphery of the this cornea periphery to the cone outward, so relatively flattening the cornea, and vision is improved. But if all these measures fail, keratoplasty, penetrating keratoplasty is the answer. So keratoplasty is an operation in which abnormal corneal host tissue is replaced by healthy donor cornea. In this picture, you can appreciate stepwise creating a buttonhole in the donor recipient cornea. We remove the epithelium, then create a specific buttonhole of a certain diameter, about 6-7 millimeter, and then we take the donor tissue slightly bigger than this hole, about 0.5 millimeter, and put it on this buttonhole and stitch with the This was all about keratoconus. Now we'll briefly discuss the keratoglobus, another type of corneal ectasia. It is very, very rare congenital condition in which entire cornea is abnormally thin. So genetically it is related to keratoconus, but onset is very early, usually at birth. And on clinical examination, you will find globular ectasia of the whole cornea, and the generalized corneal thinning is present. It may cause rupture of the descemet membrane and causing acute eye drops. And this type of cornea is usually have a rupture with a minor trauma. On corneal topography, you find generalized steepening, and you have to differentiate this keratoglobus from congenital glaucoma, in which the diameter of the cornea is bigger, but the cornea is having ectasia, and diameter of the cornea is bigger. Along with the cornea, luster is lost. Cornea is no more transparent. In case of megalocornea, overall diameter of the cornea is bigger, but it is the normal cornea. And the treatment of keratoglobus, we can improve the vision with scleral contact lens, and we can do the large diameter penetrating keratoplasty. So this was all about corneal dystrophies and keratoconus and ectasia. Ladies and gentlemen, I am thankful to you for patient listening. Now I am giving you the assignment based on this lecture. Please mention what is keratoconus and give symptoms, signs, diagnosis, and treatment of keratoconus. Please give your response on the given WhatsApp number and email. I am thankful to you, ladies and gentlemen. Thank you very much for patient listening.